In elderly and with scoliosis, I often stage the procedure. As a matter of fact, in this 80-year-old person, I did the first surgery 3 years ago, and for 2.5 years, we were having good clinical improvement, but now symptoms were getting worse. You see, patient has previous L3 to S1 fusion, and now we are going to address T12 to L3. This is the marking of the midline and disc trajectory on the skin, and then we enter the vertebral body to get bone marrow. You see the surgery start at 211, and now we enter, get the bone marrow, then we go with the probe, and we enter the kambin triangle. This is a OLLIF. You see the location. That's important because later I'm going to do a prone lateral in this level. So you see this is the kambin triangle. We are passing the border of the bone in the AP, but we are right at the border of the bone in the lateral, and then we enter the disc. You see that deflection is indicating that we are in the disc base, and then we are moving on to dilate. Look at when we are dilating, it changed the anatomy and distract the space. We go all the way to the other side. I perform a discectomy, and then here you see the disc base is entered with a cage. I put the cage to the other side to compensate for deformity, and going back here, you see that this space here significantly enlarged after the disc is placed. Now, this is now important. Since 2015, I have been doing prone laterals, and I use the same instrumentation. Patient is obviously prone. I first tried to get to the kambin triangle here, but you see with this large osteophyte here, it's really not possible. So I do a prone lateral, or what we call MIS-DLIF. Our paper has been published in 2017. Look at that. In this here, you see that in the lateral, I am within the border of the bone. I'm not on top of it like I was here. And in the AP view, I'm right at the border of the bone, so I'm not into the pedicle. So this is the difference between the MIS-DLIF and OLLIF procedure. In OLLIF, I would be here and here. So this procedure we have been doing since 2015, and our paper was published in 2017. We have few hundred of this now done, and we are entering the disc. Look at what happens whenever you enter it. I go truly horizontally, how I'm distracting the space, and then I put a cannula in, and then the rest of it is practically the same. I'm pretty horizontal. After disc-based preparation, the cage get entered. Now, I want you to pay attention to that if you see the profile of the cage is very different. And again, before here, look at that, how they are collapsed, and after. By the way, I just talked to the patient 5 minutes ago, and the radiculopathy is gone. So, and then obviously we do the same process. Patient has scoliosis, so I have to adjust the films to adjust it for the this level, for which is a 12 L1. And then in the same fashion, here we are doing a OLLIF again. So we do OLLIF, MIS-DLIF and OLLIF. And here again, after preparation of the disc base, the cage is placed. And again, look at the profile of this cage, which is OLLIF, versus profile of this cage, which is MIS-DLIF. Now, we put the Jamshidis in, and then this is the device we call facet decorticator. It goes eccentrically over the K wire and grind the surface of the facet. Then we pack it with biologic. And then the screws are placed. Here, since I have a previous surgery done, what I do is do a mini Wilstead opening and replace the previous screws in the upper two level, meaning L3 and 4, and remove L5 and S1 screws, since that levels are fused, and then practically finish the surgery. Now, the MIS part of the surgery is finished at 2:50, which is practically 40 minutes after we started the surgery. So within 40 minutes, we are able to put 3 cages and 6 screws in. And now we spent actually another hour to get the previous hardware out and connect them together. The whole surgery was 1 hour and 40 minutes. Thank you.